This week on the BackTable Podcast.
We certainly have had many discussions on the topic of burnout, but I think moral injury is, again, something that is less well understood and is more timely. Even in this survey, we asked folks, had they heard of burnout or were they aware of moral injury? And many folks were not aware of moral injury at all. So I think it's taking some time to educate the population, to educate administration, and to determine the correct terminology and understand the issues better. So we've had some initial discussions, but I think much more can be done.
Welcome to the BackTable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable Podcast. Now, back to the episode.
I'm your host, Dr. Baheti. I'm coming to you from Tacoma, Washington. I have two very special guests today, Dr. Mina Makary and Dr. Jeff Chick, both academic interventional radiologists. Dr. Makary is at The Ohio State University, and Dr. Chick is at the University of Washington. Thank you both for coming on the show.
Thank you, Ellie. We're delighted to be here today.
Yeah, thank you. It's an honor to be here again.
And Jeff, this is exciting for me because I've been outside hospital to you for a couple of years now, and I finally get to do a BackTable episode with you. So I feel like that's a milestone somehow.
Kind of amazing, too. I've been waiting to meet you for ages, and it was nice to see you on camera today.
Our topic today is moral injury among interventional radiologists. We're really going to focus on the article that you both published in Academic Radiology in November 2023. Before we get started, I'd just like to know how you two linked up to talk about this important topic. Mina, why don't we start with you?
Sure. Jeff and I have been colleagues and friends for a long time, and we've discussed a few ideas, and we both have interest in this topic, burnout, wellness, moral injury, and this was a timely topic, and we've published since then another paper on wellness as well.
Jeff, was there any specific incident that happened that kind of piqued your interest in this topic?
No, I think somewhat this developed from an interest several years ago. We published a paper on burnout in interventional radiology. Burnout had been studied in other specialties, but it hadn't specifically been studied or analyzed in interventional radiology. And the results of that study, I think, were a little bit shocking. That burnout was a little bit more common for females and more common if you worked 80 hours a week, and that it was very common in interventional radiology in general. And as we sort of explored that, we came across the topic of moral injury, which is sort of a spin-off of that. So as Mina said, this was sort of an important topic, a timely topic, and it kind of fit well with the overall wellness. So I think that's where this all stemmed from initially.
So Jeff, for those of us who maybe aren't familiar, could you kind of help me understand the difference between burnout, moral injury, and any other terms we need to understand this topic?
Of course. I think that's a very important place to start and a very good question. So in general, we sort of think of burnout as a bunch of personal symptoms, and they're sort of related to career or chronic emotional exhaustion. And we think of them as overall emotional exhaustion, depersonalization, and a lack of personal accomplishment. Sort of a key feature of burnout is that it generally implies that it's like a personal problem, like the physician or anyone in general is unable to handle the stressors of the environment, or it's more of an intrinsic thing. And that's kind of like a misnomer a little bit in medicine, because the better term I think here is moral injury. And so moral injury is sort of the feelings that you have, shame, guilt, like an overall meaninglessness. And that's when your beliefs or your ethics are transgressed. And that's because of a systemic failure. So that's an instance where it's not a physician problem or a personal problem. It's more of a physicians are unable to act the way they want to because of institutional or societal constraints. So that implies that it's not a physician problem. It's more of a systemic problem. So the main difference, I think, is burnout is like an intrinsic, a personal issue, and moral injury is the result of a systemic and a more widespread illness or injury.
Okay, yeah, I've never really had that explained to me before, but it does make sense where the guilt per se lies between those two topics. I'd love to get into the survey that you both did. Mina, could you just help me understand how you set this up?
Absolutely. So we put together a survey that consisted of some demographic and practice environment questions to understand our audience. And we used a global quality of life scale, which is a scale that measures quality of life and is scored between 1 and 100. And then we also include the MI or moral injury symptom scale, which is the MISS-HP. So there's a version of it that's healthcare professional specific, that's the HMP. And it's also scored from 1 to 100. And then we also added a couple other open-ended questions about what are the causes of moral injury in your situation and what are the solutions. So not only we diagnose it, but we get ideas from our audience, what we can do about it. And for all these surveys, specifically for the MISS-HP, the cutoff was more than 36. So above 36 indicates that the participant is experiencing moral injury. We send this 29-question survey online. We send it to IRs using the SIR forums, Twitter, social media, Facebook, LinkedIn, and email.
Was it just to practicing IR doctors, or was it to retired docs, trainees, or just everybody?
So we basically sent it to everybody. So out of the 365 surveys that we received, I can tell you that 18% were interventional radiologists in training, so residents, and almost 82% were practicing attendings. In terms of stratification, 6% of the attending physicians were less than 1 year postgraduate, almost 41% were 1 to 10 years after graduation, another 20% were 11 to 20 years post-graduation, and then 15% more than 21 years in practice.
So out of your respondents, can you give me a little bit of information about where they practice?
Absolutely. So about 40% practice in academics and 33% in the community, and 23% were hybrid, and 4% were other types of centers.
Okay, awesome. Jeff, do you want to run me through kind of the key points of the results of the study?
Sure, of course. So as Mina said, I think we had a pretty good quantification or a good stratification of folks in training all the way up to attendinghood. And we also had a good variety of folks in different practice styles, including community practice, hybrid practice, and academic practice. So the results, I think, of the study were pretty interesting and somewhat shocking. So as Mina said, the main exploration here was the quality of life and overall what the degree of moral injury was in this population. So on a whole, the quality of life for the entire survey population was 71 out of 100. And that was correlated with a good quality of life, which I think is positive for us and positive for our specialty. The somewhat more negative component is that of the people who took the healthcare professional moral injury survey, 61%, or 233 individuals, scored greater than that 36 points, and that was indicative of having moral injury. So the majority of interventional radiologists surveyed felt that there was some degree, or they experienced moral injury in our profession. I think a little bit expected. We did a correlation to see if we could correlate the degree of moral injury with quality of life, and I think it certainly makes sense. There was a negative correlation. So those that had a higher degree of moral injury had a lower quality of life, and that was strongly statistically significant.
Did you find any difference in the moral injury rates between folks who were younger or not as far along in their career versus those that had been practicing for a while?
We didn't find any specific differences in the vast majority of the demographics. Some folks who had earlier in their training reported a slightly lower quality of life.
Jeff, could you tell me about the scoring system that you used to score this survey?
Of course. So there's a moral injury symptom scale, and there's a healthcare professional version of this that has specifically been used in the psychology literature to study healthcare professionals. And this is 10 questions that globally assess all the aspects of moral injury. Those components include things like, how does a physician or healthcare practitioner feel with regard to betrayal, guilt, shame, moral concerns, any religious struggles, loss of religious or spiritual beliefs, loss of the meaning or purpose in life, difficulty forgiving, loss of trust, and overall self-condemnation. And when all of these components are put together through a series of 10 questions that attempt to analyze and assess these, as Mina said earlier, they're scored. And if the score is greater than 36, that is indicative of moral injury in a healthcare professional.
Okay. Well, what I really would love to hear about is kind of the open-ended responses that you got and what data you were able to glean from them. Mina, do you want to take it from here?
Sure. In terms of the causes of moral injury, the most common themes that we found were ineffective leadership, barriers to patient care, and those barriers can be timely and effective scheduling, disconnect between the support staff and the IRs, gaps in the up-to-date knowledge of the physicians, corporatization of medicine, non-physician administration who mandate policies that restrict the best IR practice, performing futile procedures, so pressures from referring physicians, for example, turf battles, and reduced resources. And those things include less support staff, access to equipment and instruments, dedicated time for periprocedural care like rounding and taking care of patients. And all those factors contribute to the moral injury in the survey results.
So what do we do with this data? I mean, we've identified all these causes for moral injury, but what ways can a physician decrease their own MI?
Well, as Jeff mentioned, MI focuses on the systemic context and causes, and many of the solutions are often challenging and often impractical because they require that we tackle complex cultural, systemic, institutional structures. Because MI focuses on the extrinsic factors, unlike burnout, where it focuses more on the resilience and the personal factors. But on individual studies have shown that things like psychotherapy and spiritual care and things like that can achieve moral repair. Strategies, for example, that can help reduce physician burnout, and this is not necessarily moral injury, but specifically burnout, focus on improving resilience, promoting stress management. The most common practiced intervention and well-studied intervention among physicians is physical exercise, other things like small group discussions, mindfulness. All this starts by us talking about the problem so we can affect it. But at the end of the day, if we specifically want to focus on moral injury rather than burnout per se, we have to find solutions that are more targeted towards the recurring systemic issues that lead to moral injury. Systemic issues that limit our ability to practice in a way that aligns with our core ethical values. And studies have shown that success only happens if we do that, if we go into the system level interventions and leadership and organizations and policies to improve the physician well-being rather than just focusing on the individually targeted solutions.
So you both work in large academic healthcare systems. Do you feel like there's buy-in from the organization to have a good physician quality of life or to decrease moral injury for their doctors?
I think this is, as we sort of discovered, sort of a new topic in medicine, and it's a very popular and timely topic in medicine. I think it has just come up over the past 5 years or so with increased recognition of burnout and increased recognition of moral injury. I think it's still in its infancy. I think at this phase we're talking about the issues more, and it's a little less in practice, but I think we're moving towards making steps to build this into practice. And as Mina said or elucidated, I think we're taking steps to have greater physician involvement in leadership and care. And we're taking steps to have more administrative support. But I think it's quite challenging in the time post-COVID and with limited resources. It's always a sort of a balancing act.
Yeah, definitely. Have either of you been able to engage your organizations to talk about this further?
We certainly have had many discussions on the topic of burnout, but I think moral injury is, again, something that is less well understood and is more timely. Even in this survey, we asked folks, had they heard of burnout or were they aware of moral injury? And many folks were not aware of moral injury at all. So I think it's taking some time to educate the population, to educate administration, and to determine the correct terminology and understand the issues better. So we've had some initial discussions, but I think much more can be done.
So I totally agree with how Jeff well summarized this. Basically, it's a topic and it's in infancy, but I'm very proud of how just in the last 5 years, in radiology meetings and IR meetings with our research and others, there's a lot of talk about this, and this extends beyond radiology even. And, that's the first step. And as we've gleaned from our survey, what our IR docs are hoping could be solutions, systemic type solutions would be more autonomy, less bureaucracy, more administrative support, more physician-directed leadership, more staffing. A lot of these things have been, advocated, especially in the post-COVID era in healthcare in general. And, I think there is a whole lot of work that needs to be done, but I think we're moving towards the right steps.
Can we talk a little bit about future directions of research for this topic?
Of course. I think, as Mina mentioned at the beginning of the podcast, we've just recently done some other studies as well. We looked at the global wellness of interventionalists as well, and that also was published in Academic Radiology. And in a negative way, the wellness is not particularly high of interventional radiologists either. Physical wellness is reported to be quite low, and young radiologists and residents have described lower emotional wellness, and people in academics in general have described low global wellness. And I think these are kind of good points to identify for taking the next steps or for changing things ultimately. One of the projects that Mina and I are working on specifically, or we're hoping to finish in the future, is there's a concept called moral distress. So moral distress is sort of the acute or the transient events that give rise ultimately to the long-lasting moral injury. So if Mina and I and others can help identify the acute stressors that lead to moral distress, and we can help mitigate those, and medicine and hospitals can help mitigate those, then perhaps we can ultimately reduce or eliminate the moral injury or the burnout in general, and hopefully have a more fulfilling medical career in general. I think, again, these are issues that not just interventional radiologists and not radiologists in general, but all of medicine is tackling. And Mina and I are hopeful that we can make some changes in the interventional radiology and the radiology sphere, but I think this is a major issue for all of medicine.
For those who are listening who want to do something about their situation, perhaps administrators, is there any low-hanging fruit that you have seen anecdotally that administrators can tackle to help with moral injury or moral distress?
I think, again, as Mina described in general, I think it's understanding that involving physicians in sort of the administrative aspects and in the longitudinal aspects of patient care, because we're the ones on the ground and we're the ones that understand what we're going through, and we understand a lot of the challenges in healthcare and healthcare administration. And I think our direct involvement is something that can help us reduce sort of all of the injury, whether it's burnout, moral injury, and also improve our wellness. And again, as Mina said, there are smaller things too that can help. I mean, again, having more support, having more staffing, having more administrative support, all these small interventions that could go to great lengths to help us here.
Well, awesome, guys. I'm kind of out of questions. It was a pretty well encapsulated topic, Is there anything else that you guys would like to talk about?
We just want to say, at the end of the day that moral injury is prevalent and it's negatively correlated with quality of life. It's not just, something that is an academic exercise. Awareness is the first step, but we need active, diligent changes. And also, as Jeff alluded to throughout this, is that there's a very low understanding of MI versus burnout. And with MI being specifically focused on the outside issues that affect one's core moral beliefs and practice, to repair that injury, you need to look at outside factors. And I think most of the burnout talks and things that have been done are mostly focused on resilience and internal changes, perhaps. And to really, truly address moral injury, we have to not only raise awareness that this is different, but also encourage more systemic issues. And even though they're more complex and they're harder, we have to start somewhere. So I think our message is that.
It'll be a nice little sound bite, but it's nice because then people will be able to know what's happened in your article, but won't necessarily have to read it. So it'll reach a larger audience,
That sounds perfect.
Yeah, absolutely. And thank you so much for setting this together, Ali. I really appreciated the thoughtful questions, and Jeff and I really appreciated this opportunity.
Thank you again.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
and Ali Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.